All right, I'm going to say this. And for those who know me personally and who know my story, they're probably laughing as I say this, but I got to say it after having this interview with Dr. Butts. If you're in grad school right now or you're in college and, you have a desire to really focus on your career, your career focus right now, your family planning is, I'm not having children in the near future. I would strongly, strongly recommend that you still sit down and have a conversation with your doctor about your productive reproductive fertility plan. And for those who know me personally, who know my story, I know they are tickled to death listening to me say this because I can tell you personally, when I was a resident and focused on my career, I know I had no desire to have any kind of plan except no children. And in hindsight, I'm so happy and thankful for, my gynecologist for gently inserting that conversation in because she knew what I was up against in terms of balancing a career and family planning. But now that I've had this interview with Dr. Butts and others who've been on this fertility journey, I would strongly, strongly recommend any of you that are, age of 25 to 35 and you're, in that career driven seat, go have that conversation, a focused reproductive fertility focused conversation with your doctor. Welcome to the Women's Digital Health Podcast, a podcast dedicated to learning more about new digital technologies in women's health. We discuss convenient and accessible solutions that support women with common health conditions. Join us as we explore innovations like mobile health applications, sensors, telehealth, and artificial intelligence, plus more. Learn from a board-certified anesthesiologist the best tips to fill in some of your health experience gaps throughout life's journey. In episode 5 of Women's Digital Health, we have the true pleasure and honor of interviewing Dr. Samantha Butts. Dr. Samantha Butts is the current Division Chief of Reproductive Endocrinology and Infertility at the Hospital of the University of Pennsylvania. She graduated undergrad from Harvard with honors. She graduated from medical school from Harvard, and then she did her obstetrics and gynecology residency at the University of Pennsylvania and also did her fellowship there as well. And she's been at University of Pennsylvania for over 20 years, and she's currently the division chief. We focus on answering the question, how does digital health show up in fertility? What tools exist, and how do doctors see the use of digital health in fertility clinics? We talk a lot about accessibility, addressing the importance of preventative health. And according to Dr. Butts, it's really important that we get that right for our marginalized communities. We talk about removing menstrual period shaming and removing the stigma from age and the fertility journey. We talk about digital health in terms of tracking your menstrual cycle and how you can really partner with your doctor when you use digital health tools. Do you have a reproductive life plan? Yeah, I didn't either, especially in residency. I was totally focused on, trying to finish my career. And you know what? It's okay. It's okay if you don't have one. But in this episode, Dr. Butts makes the case of making sure that you talk to your doctor about your health before you even consider getting pregnant. She makes a very strong case for asking, the importance of asking those questions even before you get pregnant. I wish I had this episode when I was in college or when I was in medical school, maybe a few of these conversations. In hindsight, I think a lot more of us who are uncertain about their fertility journey could really use a lot more information and could significantly benefit from this conversation. So stay tuned. Now, Dr. Butts is going to be using some terms in this podcast. I just want to make sure that we are all on the same page in terms of the terms that she's using. She's going to use the term PCOS or polycystic ovarian syndrome, endometriosis, and uterine fibroids. These are the top 3 common causes of exclusive female infertility. And if you want to know more about those particular infertility conditions, check out my newsletter. I believe it's my September of 2022 newsletter where not only do I touch on these common causes of infertility, but I also interview Adriana Hopkins, an Emmy Award winning journalist who talks in great detail about her journey with uterine fibroids. She's going to use a term called femtech. Femtech describes, you know, these digital health solutions that are specifically targeting women's health. And I promise I'm going to give a separate episode on femtech. She's going to use a term called ovarian reserve. That describes the number of eggs that a woman has in her lifespan and the probability of those eggs actually being fertilized and you becoming pregnant with those eggs. ASRM, that is the American Society of Reproductive Medicine. That is a large organization that Dr. Butts is very, very active in. MFM means maternal fetal health. And so that describes the symbiotic relationship that a pregnant person has with the fetus. So when you become pregnant, your health changes and that fetus impacts your health and you impact that fetus. So that's what MFM or maternal fetal health means. I love this last term, reductionist approach. She uses this term to describe the need for a holistic approach to talking about fertility. In other words, just doing one test is not enough. When you're talking about fertility and success with fertility, you have to look at a woman in her entirety. You have to look at their mental health, where they live, other conditions of other organs, their heart, liver, lungs, everything, as well as previous pregnancy complications. So I hope that will help guide you in this particular episode. This is an incredibly useful episode for those of us who are in various parts of our lives and certainly those who are beginning their fertility journey. We have a wonderful guest with us today, Dr. Samantha Butts, who's going to really help us dive deeper into the topic of fertility, which I know is a common question that I get, and I definitely needed to get an expert to give us more insight on that. So, Dr. Butts, can you please introduce yourself and tell us who you are and what do you do?
Sure. Thank you, Dr. Sinkfield, for inviting me to talk to you and engage with your audience. So I am the formal title of my subspecialty is called Reproductive Endocrinology and Infertility. And that's just a fancy mouthful of a way of saying that I specialize in the realm of OBGYN. So by trade, I'm an obstetrician gynecologist. And I did 4 years of training in that. And then I did 3 years of training in the subspecialty of OBGYN that's dedicated to a growing segment of issues that patients face, but which really leads with the fertility challenges and barriers that people have. And this is in the realm of heterosexual couples trying to become pregnant and having struggles. This is in the realm of single individuals thinking about how they want to build a family. This is in the realm of our LGBTQ patients thinking about how they want to build families as single or partnered people. It's about our patients who want to think about their future fertility and fertility preservation when it is under threat. And by that, I mean patients who have gotten a recent serious diagnosis, the treatment of which could save their lives, but could also threaten their future fertility. And patients who are being proactive and mindful about the sort of biological facts of fertility as women age and wanting to consider what their options are, including fertility preservation. The other realm of what we do in my field considers conditions of the reproductive hormones and the organs of the reproductive tract, including ovaries, uterus, fallopian tubes that can have disorders and diseases in them primarily that can affect the health and quality of life of affected people, but that can also overlap and challenge fertility down the road. So there's an intersection between these things. And so what we do is medical treatment. What we do is surgical treatment. We lead with a lot of informed counseling. And I think one of the most important things that we gather from patients is their clinical history and background. And one of the other important things that we gather from patients is what are their thoughts, plans, concerns, and what are their fears and what are their fears really about this whole realm and aspect of their lives. I have been in practice in this field for the last 18 years, and I am currently the chief of the division of reproductive endocrinology and infertility at Penn State Health and the Penn State College of Medicine. And that's a role I've had for the last 2.5 years. So in addition to being busy clinically, which I'm on call this weekend, I also have to think about the strategic goals of our group, our division, and some of the bigger questions about how patients get access to care, how care is equitable, how care is effective, how we sort of spread our message about what we do to groups of people who may not know what we do, and that our services have such a wide scope. And so that's kind of an overview of what I do.
Yeah, thank you so much. Because I think everything that you hit on, I have questions about. And just for the sake of time, I'm gonna narrow our focus, but I definitely wanted to talk about accessibility because I think that in the news there's been a lot of information circulating about the time in which those of us who wish to become pregnant want to have a child but may not be ready financially or mentally, or it's just not the right time, but yet we should be thinking about our fertility journey much sooner than maybe we were, you may have even been taught culturally to think about it. But yet there can sometimes be an education barrier, there can be a financial barrier when you're talking about this fertility journey. So how do you counsel women? Let's just use age as an example. How do you counsel women who maybe they're not thinking about fertility, but perhaps age may be a important part of this discussion to say, hey, listen, you may want to consider this, and if you're not thinking about it now, these are the things that you want to do to move forward.
So I think there has to be a component of the conversation that is universal, regardless of age. And I feel like I spend a lot of time talking to patients about this. We've got to be of the mindset that overall health and gynecologic health is inextricably linked to reproductive goals. And I feel like that's not always intuitive. And so, one of the things that I message to patients and that I message to groups that I talk to is, if a patient is coming to see me for the first time and I do an incredibly extensive intake and a history, and she tells me, my periods are debilitating and I cannot get out of bed. Or they're incredibly heavy and nobody's listening to me. That's a huge problem because that statement suggests not universally, but it raises red flags for me that there could be something going on. With respect to the functioning of the uterus or the ovaries or both, that is affecting this patient's quality of life. There's a trust issue and perhaps a betrayal because she's tried to bring it to the attention of providers, but feels like people have said, oh, that's normal. It's not. Let's Dr. Singfield, I would just say to you, within medicine and societally, we've got to stop normalizing abnormal periods for women. Within families, it has to stop. Within health systems, it has to stop. I don't know any other way to say it more plainly than that. So I think just, sure, age is an issue, but if you're 29 years old and you've never known a month with a period that is not irregular, super heavy, or super painful, such that you can't get out of bed, that's hugely problematic.
Yeah.
And so that's the approach I take with patients across the board, and we all should. I also think, having a conversation so that we take the stigma out of the conversation about age and reproduction is also
Right.
important. I feel very comfortable having that conversation because this is what I do for a living.
Yeah.
And I also think we need to be able to talk to patients and say, there are some biological, irrefutable facts.
Right.
That period. But I'm also not going to sit here and stigmatize you for decisions you've made in your life
Right.
because you decided to get a PhD and that was a priority for you. I'm not going to
Right.
shame you about that. And for some people, it's just they didn't find a life partner yet. That's okay.
Right.
So I have to be able to say to you, I'm going to do the best I can for you. I'm going to get all the facts. I'm going to do a comprehensive workup. But there are these things that influence the likelihood of becoming pregnant on your own and the chance that the treatments that I offer you will be successful or not. And that's kind of it. I don't think to continue to make people feel bad or beat up.
Yeah.
Women get this so much.
Yeah.
And, I think patients need to feel like they have the courage to show up at your office, right? I mean, there's
Right.
a lot of people who can't even get there. It's terrifying. It's frightening. They've judged
Absolutely.
themselves. They self-select out. So you
Mhm.
have the guts to come.
Right.
I'm not going to now emotionally beat up on you because of your chronological age. I'm going to support you and talk frankly to you about everything we do in the workup and the likelihood that treatments will work for you.
Yeah, that's so interesting because like I definitely resonate with this idea of, not only age shaming, but period shaming, which also gets me to question about, the value of tracking, right? Because when you begin the menstrual cycle, part of that conversation, hopefully is about tracking your periods, right? And understanding that perhaps there is a relationship between your periods and things that you should be bringing up at the doctor's office. And oftentimes I don't hear that as a part of the conversation. And I'm trying to figure out if because we have put shame around periods and normalizing the shame that those conversations go away. And furthermore, how do we navigate that well before a woman is thinking even about fertility? Is this something that we teach a girl in her adolescence, or is this something that she should add on later on as she is a little bit more mature?
I think this is an incredibly important and foundational question for
Mhm.
so much regarding reproductive health
Mhm.
and fertility. If we're talking about tech and using tech for good, the preponderance of apps out there
Yeah.
that allow people to track their period, I can only see as a generally a good thing, whether you're trying to become pregnant or not.
Right.
There are a lot of people in OBGYN and in my fields who feel like we should consider the menstrual cycle to be like a fourth vital sign for
Right.
for people who have periods,
Yes.
because there's so much about whether you're getting a period, how
Yes.
often you're getting a period, the symptoms around your period that reflect underlying elements of your health.
Mhm.
Um, Psychosocial stress, chronic medical conditions, nutritional status, medications that you may be on can affect your periods. And I consider it to be very empowering to have a sense of that. You don't necessarily have to be super detailed about tracking it. You can if that, is something that's satisfying and not overly stressing, because I've seen that
Right.
too. but just having a sense so that you can understand a pattern and then know when there's a deviation from that pattern. That's what's critical.
So, would you recommend that this is something that women have a set number of months before they come to you as to, what their menstrual cycles are like? I mean, how might one track their period and use that information in the clinic to give you better understanding of what's going on?
Well, I'm glad you asked this because I think one of the questions that you'd sent to me got into how can digital health be a tool
Right.
and things like that. And I think that digital health can be a tool for you, a self-facing tool as a patient, but it can
Right.
also be an incredibly powerful way to dialogue with your provider about what's been happening, right? It's
Mhm.
just, you have a phone on your app that makes it very easy. I would condition that on just a couple of things. So it
Mhm.
depends on, are you on birth control pills or not? And by that, I
Okay.
mean, there's some patients who are on the pill, and you can absolutely track your periods while you're on the pill. Certainly, a deviation from normal when you're on the pill is something to bring to the attention of a provider. But I think if we're talking about tracking your periods as a way of understanding the function of your reproductive axis outside of medications that
Right.
influence that, I think it can be helpful. And I think patients appreciate it when we validate what they have done and also interpret it and give them feedback.
Yeah, thank you. Thank you for saying that because I think a lot of times women don't know what to track. I think menstrual cycles is one of the more common ones, but
Mhm.
I think, a lot of times even coming into the clinic, it's like I have the information, but I don't even know how it's relevant to this conversation. And so by you saying that, like, hey, listen, when you give me this information, it actually helps fills in some of the gaps that I may or may not have had as a physician,
Right.
as a specialist trying to give you information. I think is going to be really helpful to people. I want to move into some of the different fertility tracking beyond just the menstruation. There's ovulation technology that's out here. There's like a lot of these at-home convenient fertility testing tools that I've seen, and I'm a novice. I don't know what they mean. I'm certainly interested in how technologies can enhance health, but I don't have the experience to know what that looks like in the clinic. Could you offer some of your insight in terms of what these common fertility testing technologies are and how they impact the clinic visit?
So, digital technologies have influenced so many aspects of our lives. And so
Mhm.
we knew it was just a matter of time before there was significant growth in the health sector. And there's
Yeah.
a whole sector within health related to digital health for women called
Right.
FemTech, right?
Mhm.
And so there's a variety of general categories. We've touched on some of this. There's the tracking, right?
Right.
You can track your menstrual cycle, which can be something that's useful whether you're trying to become pregnant or not. There's ovulation predictor kits, and these come in a variety of levels,
Mhm.
depending on how complex you wish to be. There are even tests that people can do at home to understand components of sperm.
Right.
Uh, sperm testing kits at home, and there are also at home fertility tests that get into this construct of ovarian reserve or
Right.
egg reserve or things like that. I think those are some of the major categories.
Mhm.
As I was preparing for this, Dr. Singfield, I went back and I was interviewed 7 years ago by The Cut, which is one of the New York Magazine um, digital magazines. And I was interviewed, and another leader in our field, who was a former president of ASRM, was interviewed too. And my opinion about this space has evolved for sure. I think there's a lot of power in digital and mobile health, but I think some of the foundational issues are stable for me. And I think there has to be a balance in our field between both. Staying true to excellent principles of comprehensive patient care and thinking about how we can knock down some of the barriers to patients, especially those who have been marginalized and have the hardest time getting there. I would also offer that those patients who have the biggest challenges with access are the ones who we should be the most focused on getting it right for. Everybody, we should get it right for everybody. I don't want to make anybody think that that's not my position. But the idea that patients who can't easily get to a doctor should have this go it alone approach and just have decision-making be driven on tests that they do at home without some engagement from an expert is not the best way to go, in my opinion. I've always seen this area as a way to allow patients to enhance some understanding of their reproductive functioning and arm them with the kind of information that can help them have a more robust and productive dialogue with a provider. And that provider can be somebody like me who's a subspecialist. That provider can be your primary care doctor, your OBGYN, so long as that has spurred a conversation. And here's why it's so important, in my opinion, because just like in life, right? Isn't there this expression, you're never as good as your best press and you're never as bad as your worst press?
Right.
I think that applies in part to this kind of testing. What we don't want to have happen is patients do a test at home, they get a reassuring result, even though they have had 3.5 years of infertility, and say, I'm good. Let's just see what happens. That is not what I would hope the result of that testing would be. The same is true on the other end. I don't want patients to do home testing, get a not reassuring result, and then get into this emotional tailspin and then can't engage, right? Anything about a test result that makes you not engage, in my opinion, is not what we want.
Right.
Hopefully the results of any testing would make you engage more because you have a piece of information. Maybe it's not the result that you wanted. Maybe it's a reassuring result, but you could say, okay, now I'm going to take this to somebody and we're going to put it in the larger context of everything. One of my philosophies, and I said it 7 years ago, and I absolutely stick by it today, is we cannot take an overly reductionist approach to anyone's health, whether it's, your general health, whether it's your kidney health, whether it's your cardiovascular health. The same thing applies to reproductive health. You cannot, and we should not, promote this philosophy that we can boil down fertility to one test you did at one point in your life.
Yeah.
It makes no sense. It makes no sense.
Yeah.
Fertility encompasses multiple facets on the female side of the equation and facets on the male side of the equation if you are partnered. And I think that is a message we have to continue to say. We have to continue to communicate within medical circles and to patients directly. It's critical.
Hey listeners, it's Dr. Brandy. Thanks for listening to this episode of Women's Digital Health. Subscribe to Women's Digital Health on your favorite podcast platform. If you want to know even more about how to use technology to improve your health, Subscribe to our newsletter on womensdigitalhealth.com. Follow us on Instagram, Facebook, YouTube, and LinkedIn. Enjoy the rest of this episode. Part of this is really defining what infertility is,
Right.
and what does it look like on a female side versus a male side. And my question is, if you're in this, if you're trying to get clarity and understanding on what infertility is, Dr. Butts, can you please first define that? And then
Sure.
secondly, if you were considering some digital health solution, whether you're a male or a female, what should you do first? What things should you consider first?
All right, let's start with definitions first. I want to also put this in some context, and this is, this is guidance that is, in guidelines that are produced by our major professional societies, the
Okay.
American Society for Reproductive Medicine, the American College of OBGYN. There are a couple of major things to consider when making a determination about whether infertility exists and when to seek care.
Okay.
I would lead first and foremost with something that we alluded to before, which is general and especially gynecologic health considerations. If you are somebody who carries a specific diagnosis that we also know could impact your fertility, we shouldn't apply the same definitions of what infertility is to you as we do to people who do not have those disorders.
Okay.
If you have a history of polycystic ovary syndrome, which is the most common endocrine disorder in women, it affects at least 10% of women in this country, not to say, and worldwide, right? Very common. This is a condition, very complex, very multifaceted, but as pertains to the functioning of ovaries, it impacts whether women ovulate or not, how often they ovulate, and anything that represents a barrier to ovulation, which is the timely release of an egg, is a complete non-starter when it comes to fertility. If you're not ovulating or ovulating infrequently, it is very, very difficult to become pregnant. If you carry that diagnosis, and let's say you ovulate 3 times a year, and somebody tells you, oh no, you're 25, but try for a year. Does that make any sense?
Right. Yep.
None whatsoever. So if you carry a diagnosis like polycystic ovary syndrome, if you have a known history of endometriosis, again, affects about 5 to 9% of women, common cause of chronic pelvic pain, pelvic organ dysfunction due to scarring, inflammation, especially if you have advanced stage endometriosis, you should not try for a year.
Right.
You should seek care early on in your attempts to try, or even before you start trying at all. If you have a history of pregnancy complications, especially early pregnancy complications, like ectopic pregnancy, which is a pregnancy that often implants in the fallopian tube, recurrent miscarriages or pregnancy loss, these are the kind of things that should direct you in an avenue towards proactive, as opposed to considering yourself like people who don't have this disorder. And I would also add to that, I said pregnancy complications. I would include, but in a slightly different vein, that any person who has had complications in pregnancy, preeclampsia, preterm delivery, gestational diabetes, that could be complicating to the outcomes for maternal fetal health, should have a conversation with a physician before becoming pregnant. A high-risk specialist, perhaps, an obstetrician for sure, to say, what are the things that we can do to mitigate the risk of that happening again? We're in this time where there's so much thought and acknowledgement around maternal mortality and maternal morbidity in this country,
Right.
we should not be missing out on opportunities to prevent those things from happening if we can. So I'll go back and just finish the answer because I went off a little bit on a tangent. But so thinking about those conditions, if you are somebody who had leukemia when you were 15 years
Right.
old, got chemotherapy,
Mhm.
different population altogether. Separate from that, we think about definitions of infertility according to age categories. For women who are under 35 years old, we typically say, so long as those conditions do not exist, that trying for a year makes sense because probably about 90% of people will become pregnant in general if they try for a year and don't have any of those pre-existing barriers. We changed the guidance for women who are 35 and older. If you've been trying for 6 months and it has not been successful, it's reasonable to seek care and consultation.
Okay.
For women who are, and I should modify that, 35 to 39. For women who are 40 and older,
Mhm.
it is reasonable to have a conversation very early on in attempts to try or even before. And I would say for any person, there is no problem with having what's called a preconception consultation, where
Okay.
you have the opportunity to talk about these guidelines, where you have an opportunity to talk about the things that we do to optimize your health pre-pregnancy, like not smoking, like
Mhm.
that is a behavior that we can all agree will make the likelihood of fertility less, will increase the risk of miscarriage and other complications in pregnancy. To talk about nutritional optimization in pregnancy, to talk about screenings that should happen prior to pregnancy, tests that you can do to understand your risks, to optimize maternal fetal health, and things like that. So that is a completely appropriate conversation for anyone to have, but especially for somebody who has had complicated pregnancies in the past or has medical conditions that could make pregnancy more complicated or make becoming pregnant more difficult.
Pregnancy preconception evaluation. I don't think a lot of people are very familiar with this because you're mentioning multiple other conditions that can contribute to infertility that sometimes may be more in the realm of preventative health rather than to your point, structural or hormonal challenges. Smoking is certainly one. Blood pressure, I think, is another.
Of course.
Blood sugar, glucose management, all of these things prior to pregnancy. I don't think a lot of people really connect the dots between those things and their fertility. So, can you help me understand how a woman may show up in a clinic and ask for a pre-pregnancy evaluation or clinic visit? Let's say she's not thinking about pregnancy, but she's heard on the news that this celebrity's getting this fertility treatment, and she wants to know more, but may have some risk factors. Like, how do you start that conversation with your doctor? Let's say
I
even with your
mean,
primary care physician, and then
sure.
ultimately to see you.
Sure. And this is the kind of testing that's not some, super obscure, inaccessible testing. I mean, we're talking about make things like screening for diabetes if you have a strong family history or if you yourself are at risk, making sure vaccine status is up to date,
Mhm.
making sure you're up to date with your pap smears.
Right.
If you are of the age where you should be getting screened for breast cancer, thinking about getting screened for breast cancer.
Mhm.
And I would offer that anybody can have a conversation with their primary care doctor, who they should be seeing on a regular basis, or
Mhm.
their OBGYN, who's hopefully they're seeing on a regular basis. And if they have a doctor who serves in both roles, that as well. To say, I'm thinking about pregnancy, maybe within the next 6 to 12 months,
Mhm.
what would you recommend I should be doing to give myself the best chance at having a healthy, uncomplicated pregnancy? And as doctors, and I'm not going to stand in a bully pulpit and wag my finger at anybody, especially knowing the incredible demands that we are under as physicians
Mhm.
in the wake of this pandemic, which we're not still completely beyond,
Right.
and the demands and limited time that we all have to offer the kind of care we would always love to offer.
Mhm.
But I, for one, think that I would love to see us get to a place where, when we're talking to patients, especially in the gynecologic realm, that we ask them, what is your reproductive life plan?
Right.
I've asked that to patients. They looked at me as if I was speaking Martian.
Yes. I think it is
Right? Your
cultural. Yeah.
reproductive life plan could be, once had a patient say to me, I'm not interested in having children. Can you just refill my birth control pill, please?
Mhm. Mhm.
That's a reproductive life plan.
Mhm.
Some patients say, well, I'm glad you asked because I'm really worried about that.
Right.
This, and this. Or some patients say, I'm interested in having children, but this is not the right time. Any one of those answers has a response that can engage the patient further in
Mhm.
how to execute that reproductive life plan. And it's also a dynamic thing. So I would also say that you can ask it once and perhaps you ask it again a year or two later and the answer has changed.
That's right. Mhm.
Yeah.
So that's a great question because you have gynecologists that, focus on wellness, but you are specialized in fertility. And so my question is always, when, obviously you may have a desire to become pregnant, that's one reason, but there should be other reasons why a fertility specialist may be consulted beyond just what preventative health gynecologists do. Can you give me more clarity as to when someone you may be referred or may want to seek out a fertility specialist?
Of course, I mentioned earlier on that we also offer fertility preservation services. And let me elaborate a little bit on what that means. Fertility preservation represents those treatments that allow for the cryopreservation, freezing of eggs, sperm, embryos, ovarian tissue for people who wish to think about fertility options in the future and who cannot or choose not to be pregnant in the current time.
Mhm.
I consult with patients who are single and want to think about freezing eggs because they haven't yet met a life partner and they want to do the kinds of things that could put them in a position for having reproductive options in the future when and if they meet that person.
Mhm.
As I mentioned before, we are often having conversations with patients to talk about fertility preservation if they have cancer,
Mhm.
if they have sickle cell anemia, which, not a lot of people know that sickle cell anemia and the severity of that condition can negatively impact male and female reproductive functioning. We are fortunately in a place right now where patients with sickle cell can be cured in some cases with
Mhm.
stem cell transplant. But unfortunately, the stem cell transplant is very powerful and can significantly damage organs of the reproductive tract such that it would be difficult or impossible for a patient to get pregnant using their own eggs or their own sperm in the future. So they've been cured of this terrible disease. This goes for sickle cell and cancer, but they cannot have or reap all the benefits of survivorship
Right.
if that is one of their goals. So we have those conversations all the time. And a lot of patients find their way to our clinics through self-referral. We
Mhm.
have a lot of savvy, very well-researched patients out there or referral from doctors who are managing these conditions for them.
Okay.
And I think, egg freezing has received a lot of media attention. I think that's generally a really good thing because it promotes awareness that this service is available.
Right. Yeah. Thank you so much for answering that question, because I think a lot of people don't even know where to start or what to do and what questions to ask. And you've thoroughly answered a lot of these questions, particularly as it relates to women's health and how you can set yourself up for success to come to a clinic visit armed with information that, quite frankly, we were not taught to have, at least not when I was growing up.
Right.
So thank you so much, Dr. Butts. I really appreciate your time. You are so incredibly brilliant, and I just appreciate all the work that you're doing to really change the narratives around menstrual cycles, fertility, and overall women's health. And I really appreciate your time. Thank you so much.
Thank you, Dr. Sinkfield, for the work that you are doing to promote messaging around these incredibly important issues, spark dialogue and conversation. And I really appreciate your work. And would love to talk again if you would have me back.
Oh yeah, we have to continue this conversation.
I would love it.
Because there's so much more. There's so much more to this.
Yes,
So
it's evolving and ongoing, and that's where the best conversations have when we're seeing how things are moving and progress.
Although I'm a board-certified physician, I am not your physician. All content and information on this podcast is for informational and educational purposes only. It does not constitute medical advice, and it does not establish a doctor-patient relationship by listening to this podcast. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. The personal views of our podcast guests on women's digital health are their own and do not replace medical professional advice.